Dear colleagues, dear friends, it's a great honor for me to speak in such an auditorium because such high persons, whom I consider to be more my teachers or scientific gurus than colleagues, are here. I allowed myself to change a little the title of my communication because I suppose that is the situation or the state of art with celiac disease in such countries of Eastern Europe as Hungary, Slovenia, Czech Republic, Poland, and so on is quite clear, but I'm sure that among nothing is known about the situation with celiac disease in Russia and former Soviet republics, and that it would be more interesting for you. So celiac disease and gluten-related disorders in Russia and former Soviet republics. The first diagnosis of celiac disease were made in Russia in the late 1970s and 80s. There were typical cases with severe malabsorption. The diagnosis of CD was unknown by most pediatricians and gastroenterologists, and all the patients were treated very long with such diagnosis as chronic enteritis, enzymopathy, or intestinal dysbiosis. This bacteriosis, this diagnosis is very popular in our country, and it means somewhat like bacterial overgrowth. Celiac disease was diagnosed only in Moscow, St. Petersburg, and Nizhny Novgorod, where pediatric endoscopy was available. Capsule aspiration biopsy had never been used in Russia. Serologic methods were absent or restricted only to anti-gliadin antibodies, and no gluten-free foods were available. Now, the so-called atypical or extraintestinal forms are diagnosed more and more often, also in adolescents and adults, but severe typical forms in toddlers also exist. Celiac disease is well known by in most of the regions of Russia, and research work is being held in many universities and medical centers. We find significant increase of age and improvement of nutritional indexes at the time of first diagnosis, from 80s to nowadays, and our data confirm the global trend of elevation of CD symptoms, although we have no asymptomatic or silent cases because of absence of screening programs in our country. Since 1990s, mass screening was held in most countries of Europe, North and South America, Africa, Near East, Australia, and New Zealand, and the prevalence of celiac disease is about 1%. Taking into account the Russian population, the estimated number of Russian CD patients would be over 1 million. But please compare. The approximate number of CD patients based on data provided by our key specialists is very low. The mass screening is absent, and at present we do not know any certain data of CD prevalence in Russia. Official registration of CD patients is mostly absent, except for few regions. There are few screening screening studies in the risk groups which show that the prevalence of celiac disease within these groups does not differ much from the European data. So CD in Russia remains the big question mark and on the world map. Serological diagnostics became more available now, but non-specific anti-glidin antibodies are still most widely used. The anti-transglutaminase assessment is also available in the regional centers. Endomysial antibodies and antibodies to deamidated glidin peptides are available in a few commercial laboratories and are not widely used. As a result, the diagnosis of celiac disease in Russian regions are frequently based on the clinical symptoms and raised anti-glidin, non-specific antibodies only. The laboratory tests when CD is suspected are made by commercial laboratories not being covered by state medical insurances, so patients or their parents must pay for them. Quality morphological diagnostics is available only in a few centers: Moscow, St. Petersburg, Novgorod, Novosibirsk. Morphometry is used in most advanced clinics with no problem with proper orientation of the biopsies. Stereo microscopy is also available, but the results of morphological examination made in regions are often very questionable and unsatisfactory, and Marsh-Abachilba or Karatsa-Villanache classification is not being used. Immunohistochemical investigation and typing of intraepithelial lymphocytes are practically absent, and also like EGA TTG deposits on the basal membranes of enterocytes. HLA typing is not a routine method of investigation. It is made also only in commercial laboratories in Moscow, Petersburg, Tomsk, and Novosibirsk. Prevalence of DQ2, DQ8 alleles is in Europe almost 100%. And for instance, in Kazakhstan, Uzbekistan, it's only 60%, in Russian and Tomsk, 70%. But in Moscow and St. Petersburg, we find these alleles in all 100% of patients. The reasons may be peculiarity of phenotypes, but it's very questionable, and we consider that a low percentage of DQ2, DQ8 alleles is due to simply incorrect diagnosis of celiac disease. In Uzbekistan, CD is diagnosed only in single clinic in Tashkent. There is no official registration of CD patients, but they have around 400 patients, and IgA TTG assessment is available. In children younger than 5 years, the upper endoscopy cannot be performed. In symptomatic cases, when there is 2 times elevated level of IgA TTG and HLA alleles are positive, they confirm their diagnosis. But no EMA, they have no EMAs. In children older than 5 years, they always confirm the diagnosis by biopsy. The EMA antibodies and antibodies to deamidated glidin peptides are not available, but they are coming soon there. The first degree relatives, children with failure to thrive, short stature, anemia, and autism, are screened by IgA TTG and HLA typing. Patients with established CD diagnosis receive governmental support in form of disability pensions. The diagnosis of non-celiac gluten sensitivity is based upon the 2011 recommendations and after CD and wet allergy exclusion. Meanwhile, growing incidence of the latter condition is reported. In Belarus, the official record of Belarus is 153 patients. They use anti-TTG and anti-gliadin assessment. The gastroscopy and small intestinal biopsy is obligatory. EMA antibodies and antibodies to diamydated gliadin peptides are not available. HLA typing is not available in most cases. The ISPCAN diagnostic criteria protocol is not used. A gastroscopy and biopsy is used for screening in risk groups also. All diagnostic procedures are free for the patients and are financed by government. Children under 18 years with established CD diagnosis receive governmental support. The diagnosis of non-celiac gluten sensitivity are made also after CD and wet allergy exclusion, but not challenge. Then, in Georgia, there is now a register in Georgia for CD patients. The prevalence in Georgia is not unknown. For 1 year, Professor Michael Lense had been working in Georgia, and he was able to find 20 extra patients, the majority with classical symptoms: chronic diarrhea, small stature, and failure to thrive. Now he's starting a study on diabetes mellitus and celiac disease. Screening programs are planned for diabetics first. TTG, gastroscopy, small lower biopsy, and pathology after MASH are available, but most patients don't have a biopsy because the parents have to pay for it. Insurance doesn't cover the biopsy. In most cases, patients are put on a gluten-free diet after positive TTG antibodies, and sometimes even gliadin antibodies are still determined. The ISPCAN guidelines are not followed by Georgian doctors. HLA testing is not available. CD patients don't receive any help from insurance or government. Before Michael started, there was no dietetic guideline in Georgia for celiac patients. Together with a Georgian nutritionist, they have written guidelines for CD in Georgia, and also they are using Russian book on celiac disease because everybody speaks their Russian. Gluten-free products are available because buckwheat, cornbread, and chumiza, a sort of millet, is a part of Georgian nutrition. Therefore, these products are available in supermarkets, but ready-made substitutions are not available in the country, and they need to be imported from abroad and are very expensive. Non-celiac gluten sensitivity is so far not diagnosed in Georgia because nothing is known about it. The situation in Latvia is the best. The prevalence of celiac disease in Latvia based on serologic screening among adults is about 0.4%. There is a register of CD children aged beyond 18 since 2005, but not for adults. The number of CD patients in the record is approximately 1,500, and the overall numbers of patients, including adults, is about 4,000. IgA IgG tests for antibodies to tissue transglutaminase, HLI typing, and duodenal biopsies are available. The last scan diagnostic protocol is in use. Children and students with CD beyond 24 years of age receive monthly aid of 106 euros from the government. Mandatory CD screening is held in patients with diabetes and autoimmune thyroiditis. Since 2014, the Euro Commission regulation works in Latvia in accordance with that. All products are labeled with 14 food allergens, including gluten. The diagnosis of non-selective gluten sensitivity was established in few patients by medical consilium. There are some data on Estonia. No new cases of CD were found in the 10H serological follow-up in Estonia. And in the Lithuania, the prevalence of CD is 0.2%. Summary is the absence of mass screening. Only a few screenings at risk groups lead to absence of CD prevalence data in Russia. Absence of state programs of scientific research on celiac disease also. Low availability of well-informed timed serological and genetic examination with, when celiac disease is suspected. Main analysis held by commercial laboratories, limited facilities for timely endoscopy with intestinal biopsy and quality histological examination of the biopsies, and low skills of pathomorphologists in regions. The use of anti-glidin IgG antibodies at CD diagnosis. All these facts lead to a widespread prescription of gluten-free diet as evantibus, which leads to diagnostic mistakes, necessity of gluten challenges, and delay of proper diagnostic for years. The diagnosis of non-celiac gluten sensitivity becomes much known by pediatric gastroenterologists and is made according to recommendations of 2011. The numbers of patients with non-celiac gluten sensitivity is growing despite the fact that this nosological form is absent in the international disease 10. Traditional Russian cuisine is rich in gluten ingredients. Insufficient understanding of the necessity of strict and lifelong compliance to the gluten-free diet by patients, their relatives, and many doctors. Impossibility of gluten-free diet in the kindergartens, schools, sanatoriums, summer camps lead to social deprivation of a child. Paucity of domestic gluten-free substitutions and imported gluten-free products are expensive and in some regions unavailable. Presence of hidden gluten in manufactured products and no appropriate labeling. No state documents which can force the manufacturer to label the gluten-containing substances in their products, including drugs and medications. There is no any social support in CD patients in most Russian regions. But the things are not so bad as they may seem. We are very enthusiastic. We wrote some monographs on CD issued in last years, which are shown. We are proud to take part on in the international pro-CD study now. The number of our patients is growing as the number of and activities of CD patients societies. So Thank you very much for your attention.